Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a very specific topic to talk about, something I'm very excited to talk about, something I have been seeing lots and lots more in Vegas. It's one of those things that I don't think we saw many years ago in pediatrics, but like cholecystitis and type 2 diabetes, we see more and more kids with this. I'm talking about hyperemesis syndrome from cannabis use, which is something I see a lot in Vegas. And a few weeks ago, I got an email from a fan who is apparently an expert in this and has done a lot of reading and a lot of research into it. So I decided to bring him on the show and talk about hyperemesis syndrome. So welcome, Biren, to the show. Thank you very, very much for joining us in PEM Rules. This is something I'm very excited about because the topic for today is something that I've been kind of fascinated with. I gotta be honest, in Florida, in Pittsburgh, not too many kids, if any. Massachusetts, the same. Not sure about Florida. I don't remember a lot of kids in Florida, but a lot of kids in Las Vegas, being the party city that it is. So I'm super excited to host you today and talk about this topic. Biren, let me just introduce you to the listeners. And you're gonna stop me at any point if I made a mistake. You are originally from New Jersey. You went to New Jersey Medical School in Newark, what used to be UMDNJ. Now it's Rutgers University, right?
Yep.
Graduated in 2008. Then you completed general emergency medicine residency at New York Presbyterian Hospital, graduating in 2012. After that, worked at Allen Hospital, Columbia University, Irving Medical Center, and Morgan Stanley Children's Hospital of New York, before making the move to Hackensack University Medical Center in 2020, where you work in the pediatric and the adult emergency department. And again, it's not adult emergency department, it's a general emergency department where you see kids. So I guess you see kids in both of your facilities.
So we see in Hackensack, we see 18 and up in the adult. There's an adult emergency department, 18 and up, and then the pediatric is 17 and younger.
And just so everybody's clear, this is kind of a choice to work in the pediatric emergency department despite not being PEM trained, which is great because we certainly need the help and a lot of places don't have enough PEM trained. So having individuals like you who don't shy from working in the pediatric emergency department is super helpful. Thank you for doing that. And if you know the show, and I guess you do know the show, I'm very flattered. First question, what's your definition of a good PEM provider?
First, I just want to say thank you so much for this opportunity. I'm a huge fan of the show, a longtime listener, and I use your pearls all the time when teaching my residents. I think that a good pediatric emergency medicine provider is someone who knows how to slow things down, take a good history and physical, and order tests appropriately. So much of the trend in medicine is to front load the testing, shotgun labs or radiology for the sake of expediency, without developing a pretest probability based on a good clinical evaluation. Then we get this data and we're trying to reconcile it with the patient in front of us. But a good doc listens, does a careful exam, and performs appropriate, cost-effective testing.
I could not agree more. So happy you said that. It's one of the rules to be a good PEM doctor. You got to get a good story. I don't know if you remember my story. I must have told it some other day in some other episode. When I was doing the adult ER as part of my fellowship, I was introduced to the term rainbow. Every patient, when they check in, they get a rainbow. And one of the nurses approached me about this guy who just checked in, and he said, "Dr. Ivan, do you want a rainbow?" I'm like, "I have no idea what you're talking about. I love rainbows. What does that mean?" So yes, I think we certainly, even in the pediatric side, over-test, over-treat, over-worry, over-irradiate. Yeah, I think we probably can all use such an advice. Thank you very much for saying that. Next question. And again, the topic of today is cannabis hyperemesis syndrome, which again, since coming to Vegas, I've seen a lot more. It probably has to do with geographical location, maybe has to do with time, because I do believe it's becoming more common with time. You'll tell us if I'm wrong. And it's quite impressive. So, I have a lot of questions for you about this, but, I got to say first, as a pediatric provider, I always worry about the teenager who's vomiting a lot. And let me explain to you why. Tell me what you think. We know that vomiting is one of our reflexes, coughing is one of our reflexes, and your reflexes are stronger when you're younger. So kids cough really badly from a URI. Kids vomit very easily from gastroenteritis. But really, as you get older, those reflexes are not as strong. So an adult doesn't become febrile very easily. Usually, when an adult is febrile, there's something there more than just rhinovirus. And it always makes me a little bit more worried, a lot more worried, when a teenager who's essentially physiologically almost like an adult vomits a ton. So, is there an ectopic pregnancy? Is there a surgical abdomen? And with these kids, it's none of that, but it's almost inevitable. Going back to what you were saying about testing and being worried about getting sued and missing something, it's almost inevitable not to test them for a lot of things. So, tell us first, how common is hyperemesis syndrome? What's the epidemiology of it?
Absolutely. You bring up some excellent points there, especially about like the presentation. These patients do present dramatically, so I'm glad that we're talking about this. It's difficult to accurately track the trends in cannabis use in kids because it's so widely available legally and illegally and comes in many different forms, smoked, edibles. But one thing we can definitely say is that ED visits related to cannabis use is on the rise in the pediatric population. Last year, the CDC published data showing that from 2019 to 2022, ED visits for cannabis use in kids skyrocketed. Now, some of these visits are for an unintentional cannabis exposure in a young child who presents with like altered mental status, but consider in that same study, more than 90% of cannabis involved ED visits occurred in those aged 15 to 24 years. It's not a stretch to say that many of those visits are going to be for cannabis hyperemesis syndrome. Now, cannabis or cannabinoid hyperemesis is a disease of habitual, or if you can forgive the pun, chronic cannabis users, and has literally been described as the, quote, coming storm in adolescence.
Very interesting. So, yeah, I think all of us kind of feel that we see more of it. I agree with you. It's always kind of unfortunate when it's a 3-year-old and then CPS has to get involved and there's a whole different aspect of what to do and what to worry about. But yeah, no, thank you for those numbers. I think we all kind of know it, but it's good to know that is indeed the case so we can be prepared. So can you tell us a little bit about the pathophysiology of it? It seems to me that, it's some kids, some teenagers are specifically susceptible to it because hundreds of people use cannabis and it seems to be a group of very unlucky individuals
Right.
that happens to them, because otherwise you and I will be seeing hundreds of patients with this. And thank God we see a lot, but not that many. So how is that happening?
Absolutely. So again, cannabis hyperemesis is a syndrome of habitual cannabis users. And I remember the first time I saw it, almost 20 years ago, I was shocked by this picture of a diaphoretic, agitated patient sticking his finger down his throat to induce emesis. And I thought, gee, this seems almost neuropsychiatric rather than something going on in the tummy. And it is. Cannabis hyperemesis syndrome is recognized as a disorder of gut-brain interaction by the gastroenterologist. And they proposed 3 diagnostic criteria for it. First, you've got a patient with prolonged cannabis use, habitual cannabis use. Second, you've got this pattern of episodic, intense vomiting attacks with a return to baseline in between these attacks. And lastly, you've got relief of vomiting by sustained cessation of cannabis use. Now, we might not see that last one, but it's important to educate patients about it. Cessation of cannabis use is curative for cannabis hyperemesis. But why does cannabis hyperemesis happen? There's a few theories. One holds that the very lipophilic THC, which is cross the blood-brain barrier and gets stockpiled in habitual cannabis users, for some reason it gets released into the bloodstream in this massive reintoxication effect. And that's just one theory. It's not really clear. After all, isn't cannabis supposed to be good for nausea? And the sense of disbelief among cannabis hyperemesis patients has actually been very well documented with qualitative studies showing that many patients, despite multiple ED visits for the same, don't believe that cessation of cannabis will be curative for the cannabis hyperemesis syndrome.
Very interesting. So essentially what I hear you say, and that's kind of really important for me to understand. We say in medicine, never say never, but this is something we should never see in a first-time user.
This is not
going to happen.
Right. This is not a first-time user. I mean, you're dealing with adolescents. They might just say, I used it once.
Yes.
So that's the joy and the wonder of treating the adolescent patient population. But
Yes.
no, it's not just the first time user who presents with like cannabis hyperemesis syndrome. One of the diagnostic criteria is that it has to be a prolonged cannabis use.
So if the teenager is telling me it's the first time I'm doing it, clearly he or she are lying.
I mean, it's important to think of other causes of what might be causing their this constellation of symptoms, and there are other things which are dangerous, which you had to think about.
Yes.
But oftentimes, yes, like patients will not be straightforward about their cannabis use. Like even when you interview these patients away from the parents, I mean, I think that unfortunately, it's a very challenging patient population to get a history.
Every morning I wake up and I thank God there are adolescent doctors who can see adolescents and I don't have to do it. But yes.
They're doing God's work.
Yes, thank you, God. So let's say, and again, I see this adolescent patient, looks like vomiting a lot, and he or she say, I haven't smoked, I'm not using. Is there a way beyond the talk screen that you can tell us on the history, the physical, the story, that you can help us recognize those patients?
Sure. There are some telltale signs that have been recognized in the literature. First, and actually this is one of the minor diagnostic criteria for cannabis hyperemesis, is the role of hot showers, prolonged hot baths or showers for symptom relief. Another commonly seen sign is this agitated, frenzied vomiting, which is colloquially known as scromiting or screaming vomiting. It's often associated with diaphoresis and self-induced vomiting, sticking your finger down your throat. And of course, there's the cyclic nature of this syndrome. Many of these patients will have had similar such episodes. So even if they vehemently deny cannabis use or hand you tap water for a urine sample, gently asking them, hey, has this ever happened to you before? That can be a very high yield question. Now, it's very important to recognize that diaphoresis, agitation, severe vomiting, these can be signs of other much more serious illnesses as well. So don't anchor on cannabis. Do your due diligence with a thorough exam and serial reevaluations. Remember that things like ischemia can also cause agitation. I remember a case where we had an adolescent who was diaphoretic, vomiting, agitated, and we were all sure that this was cannabis hyperemesis, but he never had these symptoms before and had focal tenderness on serial abdominal exams. And sure enough, he had sigmoid volvulus. Reevaluation and serial exams will help you appropriately work up the patients you need to instead of over-imaging cannabis hyperemesis patients.
That goes back to rule number one. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. I would still consider hyperemesis syndrome as, not particularly sick, but somebody with sigmoid volvulus, most definitely. That's kind of a scary story. That's really, really good that you guys found that. I guess that's impressive. Now, I think, being a PEM provider, and as we discussed about kids and how they become symptomatic more easily, I obviously treat a lot of children for vomiting. So I see a lot of kids every shift with gastroenteritis. I just worked an overnight. This kid woke up, vomited 6 times. Again, barely exam is normal, non-bloody, non-bilious, no red flags. He also has some diarrhea, which makes it easy. So I do treat vomiting very, very often. But specifically, let's say, I memorize the criteria. I see this teenager, he or she admits for being a cannabis user. Is there something beyond the regular, so to speak, IV Zofran and fluids, and maybe checking the electrolytes that you recommend we do? Something specifically for this condition?
Absolutely. Just as we talked about that this patient population can be challenging, the diagnosis can be challenging sometimes, the treatment is a little bit different. And it's, conceptually, I think it's important to look at 3 domains of treatment for cannabis hyperemesis. You've got 1, your abdominal pain, 2, the nausea, and 3, the agitation. And these 3 foci can be more or less intense for different patients. Some patients are more nauseous than anything else. Some are just super agitated. You've got to tailor your approach to the patient in front of you. But where to start? There's been some research on this in kids, and even though the data is retrospective, there's a clear winner, that the atypical agents work better for cannabis hyperemesis than ondansetron and metoclopramide. So for cannabis hyperemesis, we're talking about the butyrophenones, haloperidol, androperidol. We're talking about benzodiazepines. These are effective medications for nausea and vomiting. Plus, they're obviously treating the agitation. They even have a proposed role in pain relief. So we're hitting all those three domains we talked about earlier. And some listeners might be thinking, gee, aren't those psych medications? And you've got to remember that this is a gut-brain disorder. Haloperidol and droperidol work really well, and they are in fact recommended in the GRACE 4 guidelines from the Society of Academic Emergency Medicine on treating cannabis hyperemesis. Benzos in some pediatric studies have been shown to be the most effective agents for cannabis hyperemesis. Just remember, if you mix benzos with haloperidol or droperidol, you'll have a very sedated patient on your hands. And some other caveats. There's a black box warning for haloperidol from the FDA against giving it IV. Lots of places you can only give it IM. I think that's fine. I think it works great IM. Similarly, droperidol had a black box warning in place regarding cardiac arrhythmia since 2001. Now, this has been thoroughly investigated, and even the American College of Physicians in 2021 came out with a very strong position statement saying that no special cardiac monitoring was necessary in the dose range of droperidol you'd be generally giving for cannabis hyperemesis. At the end of the day, follow institutional protocols. Like I tell my residents, rule number 1, don't get fired. Rule number 2, do no harm. And a plug here to avoid opiates. I think we like to be attuned to children's pain and treat it aggressively, and that's okay. But remember that cannabis hyperemesis is a chronic disorder. IV opiates cause euphoria, and IV opiates beget more IV opiates. You're creating another problem, which is opiate habituation, instead of treating the problem that they came in for. As an alternative, you can try capsaicin cream rubbed onto the belly. It sounds cruel, but there are retrospective and even prospective studies that have shown more complete relief of symptoms and decreased length of stay in the ED. Lastly, as LeVar Burton used to say in Reading Rainbow, don't take my word for it. There are excellent evidence-based clinical pathways for cannabis hyperemesis from children's hospitals at Johns Hopkins, from Minnesota, and these are all available online, easy to access.
Excellent to know. This is super helpful information. I gotta say, I don't think I knew most of what you just said. I'm glad we're doing this. I'm curious, Biren, if you ever had to give a child, a patient, so much haloperidol and or benzos, because you were saying something about the sedations to the point that you had to intubate him or her?
That's never happened. I think that a lot of the patients, agitation is a big part of their milieu, their presentation. They come in, they're throwing themselves on the floor. You know, the parents are obviously beside themselves. They don't know what to do with what's going on here, maybe, and they're sticking their finger down their throat. And certainly in those cases, I've had to treat the agitation more than anything else. And I've had to get them a little bit. It gets them to a point where they're sleepy, but certainly never to the point where they had to be intubated or anything like that. But it's just something to be aware of because, giving haloperidol and, droperidol is great, but they're also sedating medications, and benzodiazepines are sedating medications. You give them together, you're essentially giving 5 and 2, like we give for agitated patients that come into the emergency department.
Yeah. Interesting. Very, very good. This is, super helpful information. I guess, Biren, you put together kind of a summary, pearls and pitfalls for us, because this was, again, very detailed, very helpful. Put it all together for us.
Absolutely. So a few things to remember when treating cannabis hyperemesis. So cannabis hyperemesis, it's a common problem. It's an increasing problem in the adolescent population. It's coming to an ER near you. Adolescents are often difficult to take care of, period, but look for the telltale signs of recurrent symptomatology, agitated vomiting, relief with hot baths, and of course, if they admit it, habitual cannabis use. Always keep a broad differential. Agitation in the setting of abdominal pain can also mean badness. Reevaluation, serial abdominal exams are essential. And remember the 3 domains: agitation, nausea, and pain, and tailor your approach to the patient in front of you. Avoid opiates. Instead, don't be afraid to treat with haloperidol and droperidol. Try capsaicin cream rubbed onto the belly. Try benzos. Counsel your patients that cessation from cannabis is curative. They might or might not believe you, but it's the right thing to do for the patient.
Absolutely. This is great. So super, super helpful information. Again, something that not only we're seeing a lot, I can totally see what you're saying, that we will see this more and more.
Yes.
So us emergency providers better become more and more comfortable with this. Lastly, Biren, you know the drill. You are the guest. And as a thank you and recognition of your time, because most of my guests are very, very busy individuals, you get to choose the outro of your choice. I don't think I heard that song. What was that song that you chose?
So first of all, I'm super psyched. I'm really. So the song is 100 Miles.
Okay.
It's a folk song, and there's a version of it in this movie by the Coen brothers called Inside Llewellyn Davis, where there's like an all-star, like I think Justin Timberlake is singing, and I still use that song to put my son to sleep. And he's 7 years old. It's since he was a baby, I've been singing him that song to put him to sleep. So it's it just has that like nice feeling for me.
All right. So I can tell you, I often bring my guitar to work and play for some of the patients and play in between seeing patients. Maybe I can play to this hyperemesis syndrome patients, put them to sleep.
You could publish on that. That would be great.
I'll put it on my list. Yeah. Biren, thank you very, very much for coming on the show. This was super helpful and very interesting. I appreciate your time. And, if something like this comes up again and we get another mini epidemic of some other ingestion, by all means, you and your colleagues are invited to the show so we can learn more from you. You seem to be an expert in this.
We certainly see a lot of it.
Thank you very, very much for coming on the show. Thanks a lot.
Thank you.
And that is it for today, guys. Thank you very much for listening to PEM Rules. Like Biren, all of you are invited to come on the show and talk about a clinical case or a clinical condition, something you are experts of and just want to share your opinion. Really, anything you think will benefit other PEM providers, please contact me through the website or any other way you want, email, whatever works. I would love to have you on the show and you get to choose your outro. Please check out the Facebook page and check out how you can contribute to PEM Rules. There's a new PEM Rules store and there's a link for supporting PEM Rules on the website. I would love to have the support. Thanks again for listening. And here is 500 miles like Biren asked. Hope you have a great day. Thanks again.